Assalamualaikum warahmatullahi wabarakatuh. My name is Nurarina Syahirah Binti Nurdin. This presentation is about two articles. First article is about home-based bimanual training by Schneckers et al. In 2018. And another one is about a motor learning therapeutic through an assistive robot by Buitrago et al. In 2020. First of all, the purpose of this presentation is to determine which intervention is more effective between the two articles by Schneckers et al. 2018 and Buitrago et al. 2020 in therapeutic motor learning intervention among children with cerebral palsy. Next, what is motor learning? Motor learning is an internal process in obtaining a specific skills, which the result is to produce relatively permanent changes. In motor learning, it is associated with practice and experience, also referred to acquisition, application, and maintenance of motor skills. Okay, what is cerebral palsy? Cerebral palsy is a group of permanent neurodevelopmental disorder of movement and posture and can cause activity limitation with motor impairment. Thus, the objective of this study is to determine what are the differences of the components between the two articles and which intervention is preferred the most. In a study by Schneckers et al. 2018, the study design is independent study, which is described the protocols. The study setting is home-based training, which is participants' home. The objective of the study is to improve bimanual skill of cerebral palsy children with minimize the parental stress. The criteria of the children is unilateral spastic cerebral palsy, age 2 through 7 years. Throughout 2 to 7 years, the child's manual ability is from 1 to 3. Meanwhile, the gross motor function is level 1 to 2. Next is study by Buitrago et al. 2020. The study design is single case study. The study setting is center-based training, which at Neuro Rehab Center in Colombia. The objective of the study is to improve the child's participation and therapeutic motor learning to walk with using assistive robot. The criteria of the child is 8 years old with dyskinetic cerebral palsy. The level of gross motor function, manual ability, and communication function is level 3. The child does not have any health complication and able to interact and understand the immediate context. The study procedure by Schneckers et al. 2018, it consists of two phases. First phase is the preparation of home-based training. In preparation phase, there will be an assessment and goal setting, which is to identify and rank the child's problem in activities of self-care, play, and leisure by using COPM Child Adapted Version. Then the therapist will transform into SMART goals. After done assessment and set goals, there will be a meetings with coaching professionals. The coaching professionals are the therapists and remedial educationalists. The therapist will discuss the family situation and home environment, and as for the remedial educationalists, they will be assess the aspect of parents and child interaction and also organization of family life. After meeting, they will design a program training. A video recording that have been made by therapists is for the child's performance activities. Then, the parents are instructed on how to apply the training based on the design program. Lastly, there will be a home visit by therapists. For the second phase is a home-based training. The child will receive 3 hours and a half every week with average of 30 minutes per day of bimanual training with the total of 12 weeks. During the training, parents are instructed to record a video of training session. The parents required to register the training activity, that is to know how much time, what activities used, and detail of the training of that day. For telecoaching, parents will get chances to ask questions, address problems to the remedial educationalist, And also, there will be a home visit by therapists that take place on week 5 and week 9. That is to train in the upcoming weeks. On the third week, remedial educationalists will contact over phone to discuss the process of home-based training and source of the stress and how to cope with the stress. For the study procedure by Butrago 2020, there will be a 16 session, twice a week with 45 minutes each. It consists of 2 sessions. First session is a conventional therapy which focuses on motor skills control. For second session is motor learning to walk using the robot. During the session with robot, first the child must sitting with carry a toy, then asked to stand and begin to walk toward the robot. If the child fell on the first attempt, the child will be asked to start again. On the second attempt fail, the therapist encouraged to get up and continue to walk. When the child arrives, the child will touch the robot so that the robot will give positive feedback. The training will be repeated on the other way back when the robot gives instruct to bring another toy. The variable or parameter in article by Schneckers 2018 are the home-based bimanual training on implicit and explicit motor learning. Meanwhile, by Butrago 2020 is the number of steps without falling. The outcome measure used by Schneckers et al. Are the Goal Attainment Scaling, Canadian Occupational Performance Measurement, a child-adapted version, and Assisting Hand Assessment. Meanwhile, only Goal Attainment Scaling is used in Butrago 2020. As for the result in Schneckers 2018, implicit motor learning is expected to improve in child training, and the burden of the parents are reduced, as they were involved remedial educationalists. In Butrago et al. 2020, the result is the child managed to increase the number of steps without falling throughout the 16 session, with increase in 8 steps on the 5th weeks and the total of 31 steps without falls on the 16th week. The limitation in Schneckers' article, the study does not mention any details of the intervention, the frequency, intensity, time, and the type of the exercise. The study also does not provide any specific intervention based on the stage of motor learning, as there were 3 stages, which are cognitive, associative, and autonomous stages. Meanwhile, the other article, the number of steps without fall was due to the motivation generated by the robot. Also, there were not mentioned any specific attempts that should have been made. Lastly, if the child took a rest, he will be more likely to perform the next attempt with greater stability and control. In my perspective of the study design in Schneckers et al., it shared the information about the intervention which is better. For Butrago, the design is better as it can observe the participant using the data and able to turn the opinion into facts. For study setting, home-based training is more flexible, low cost, less exposure to germs, and less stress among parents. In center-based training, the time is limited in office hour only, with higher cost and more exposure to germs. As for objective by Schneckers, it is more broad and not specific, which is bimanual skills. And as for Butrago, the objectives are more specific, which is motor learning to walk. The participant in Schneckers 2018 is having unilateral cerebral palsy from 2 to 7 years, and in Butrago 2020, the child is 8 years old without any health complication. For study procedure, the training prescription of the home-based training is based on the design of individual training program. Meanwhile, the center-based training involves conventional therapy and a session with assistive robot. The variable or parameter of the home-based training are the bimanual training on the implicit and explicit motor learning. As for the center-based, the use assistive robot is the number of steps without falling. The outcome measure that used by Schneckers are first is GAS, that is to progress the rehab. Second is COPM, that are based on the self-care, play, and leisure. Lastly is AHA, that for the hand function. As for Butrago 2020, only use the GAS to see the progression of the step without falling. The result by Schneckers show that implicit lead the motivation improvement. The result can be used not only for upper extremities, lower extremities also can. In addition, with remedial educationalists, the stress in parents on how to handle the program will be reduced. In Buitrago et al. 2020, the child able to increase the number of steps, but this article only valid in the children who wants to improve in walking. Lastly, the limitation in Schneckers 2018, it does not mention any details of the intervention progress. Meanwhile, in Buitrago 2020, there is no specific attempts should have been done to get the positive results. As for conclusion, the intervention that I prefer the most is the article by Schneckers et al. In 2018. First, because the implicit motor learning can be applied on both upper and lower extremities. In parent perspective, it was more flexible in time, as parents can do the training on their free time. With the remedial educationalist, it is more effective. As for the child, every children have unstable emotion if they see any unknown person. So, when the parents handle their own children, the training will be more effective. Lastly, even there are no advanced equipment at home, parents can use any available toys.